As you can see, there's 6 famous women: Brooke Shields, Princess Diana, Drew Barrymore, Adele, Cardi B, and Gwyneth Paltrow. There's one thing that all these women have in common, and that is that they all have postpartum depression, also known as PPD. PPD is not a unique experience, as it's known that 1 in 7 women experience PPD within their first year of giving birth. So if you think about it, there's around 4 million births each year in the US. So that means that around 600,000 women will experience PPD each year. Good afternoon. My name is Fernando Lopez, and we're going to be talking about postpartum depression.
My name is Caterina Jennery.
Isabel Mendez.
My name is Emilio Joby Joseph. Our research question is, to what extent do first-time parents experience the effects of PPD? And our argument for this is, first-time parents experience the effects of PPD to the large extent, to the point that it affects their child into their adulthood. It also affects their family members and those around them.
While postpartum depression has been commonly associated with mothers, it also affects fathers as well. In fact, approximately 1 in 10 fathers experience male postpartum depression, otherwise known as paternal PPD, which often goes undetected and undiagnosed. In this chart, you can see multiple studies regarding paternal PPD and the father's experiences. In the first study from Sweden, it says that fathers were low educational level, low income, had poor partner relationship quality, and had financial worry that will increase the risk for depressive symptoms. While in the second study from the UK, fathers searched for their role position in relation to partner, child, and work. Fathers felt emotionally and physically detached and sometimes experienced sense of belonging and involvement. Although in most families, mothers play the role of primary caregiver, but fathers also play an important role in the lives and behavior of children as well. Overall, the paternal PPD has stemmed from feelings of lack of support, as well as having lower incomes and education, and lack in their relationship and financial worries. This caused them to become irresponsible in their parental duties, and because unlike in other generations, men are expected to be present and involved in the lives of their children.
As we can see in this graph, we can see the emotional regulatory capacity of children dealing with PPD, or children with parents dealing with PPD versus children without. Infants with parents with postpartum depression had an increased risk of emotional regulatory problems, whereas vice versa, children with parents without PPD did experience a decreased risk. It is well known that PPD affects mothers, but as Isabella said, it also affects fathers as well as the family. Quote by Dr. John Krzyzkowski stated that infant exposure to PPD is linked to emotional, behavior, and cognitive regulatory problems and can affect cognitive problems as well as increased risk for adulthood depression.
As you can see in this graph, it shows the 3 categories of child development: parent-child relationships, parent responsibilities, and parent-core life skills. Parent-child relationships may be affected by PPD in a way that it makes it so the parents can take care of their children. As stated by Dr. Sabrina Koch, fathers with PPD have worse pattern interactions with their children. This can cause behavioral problems in the children's life because they don't have the orientation from both parents. The parent responsibilities are often neglected by parents with PPD. And as quoted by Tiffany Fields, caregiving practices like feeding, sleeping, and checkups are often neglected by parents with PPD. This can take a toll on the child's health because they're not getting attention or their needs met. Lastly, parent core life skills. While parents are busy taking care of the symptoms caused by PPD, they could end up forgetting or not paying enough attention to their child and ignoring their needs and their own struggles.
So an important part of postpartum depression is the stigma associated with said problem. This graph shows a study conducted by professors from multiple universities of Virginia, and a pool of women were asked questions, and the important word in the study was ashamed. They were asked a variety of questions, whether they would feel ashamed taking prescription medicine, or whether their fellow peers, community, or workplace would shame them for taking the medicine. So the majority of the women said that they would not feel ashamed if they were taking prescription medicine prescribed by a doctor, but when it came to telling their community and workplace, as well as receiving mental health counseling and telling friends and family about that, they all voted yes, that they would feel ashamed. So this is one of the major issues, as that when there is less communication and conversation about the problem, it increases its effects. And adding on to this treatment, there is a discrepancy between white and black women and their acceptance into treatment. Both prescription medication, mental health counseling, and herbal remedies show that white women are more likely to be accepted into said therapies rather than black women. And this is because of illiteracy, low income, and even cesarean sections can have an effect on whether women are admitted into postpartum therapies.
Many mothers dealing with PPD can have some side effects, such as anxiety and loss of sleep, but not known to many, it can have some extreme side effects, such as maternal death rates, as shown by a recent study published by JAMA Psychiatry. Researchers observed the prevalence of suicidal ideation and intentional self-harm of pregnant and postpartum women appears to be on the rise. Increased by the thoughts of death in the mother's mind when they can't handle their symptoms properly. As shown by this pie chart, suicides accounted for up to 20% of postpartum deaths are related to maternal deaths. According to Patricia M. McGovern, in 1992, the European Union Pregnant Workers Directive was issued, under which of the 27 member states of the EU must guarantee a minimum of 14 weeks paid job-protected maternity leave as a health and safety measure. This image displays a breakdown of the minimum requirements passed by the EU.
Our solutions and their limitations. Our solution 1 was more awareness and advocacy for the effects of PPD. But the limitations were, as we spoke about before, the stigma and lack of participation from those who are willing to advocate for it, and especially funding for the advocacy. Our solution 2 was counseling and support groups. However, it's difficult for low-income families to participate in, and the availability is low. And funding for these support groups can be very difficult, and it can be influenced by political decisions and priorities. Solution 3, increased funding and programs. Work benefits, maternity, and cash checks for programs are such an example of the programs, as mentioned before. Some limitations of this is low income, and PPD isn't included in many healthcare and insurance coverages worldwide. However, we decided that for our solution, it would be best to have a combination of the three, as it would help the most people and help the effects the most. Thank you.
All right, we're just going to work our way across. Reflecting on your colleagues' work, which one had the greatest impact on your overall understanding of the issue?
I would say Isabella's IR had the most understanding for me, because they talked about mainly the problem of postpartum depression, while mine was political, so it talked about the solutions for postpartum depression. And hers talked about how it affected mothers and fathers, and not just the woman with postpartum, so that helped me a lot.
All right. Kat, what's an example of an argument from one of your peers' reports you guys didn't use, and why didn't you use it?
So I believe part of Millen's paper, he included a lot about funding for postpartum depression, and while we didn't use statistics from his paper directly, it was included in mine with social and funding for treatment. So while we didn't use things where the federal government would allocate money to certain treatment facilities, we did include it and say that there's a discrepancy between acceptance into treatment.
All right. If you had a fifth member of your team, what could they've added to it that would have made this a better presentation?
While we had a wide coverage of the idea, I believe personally that the best way to include something else would be geographical, because while we did mention other places, like I mentioned Sweden in the beginning of our presentation, there wasn't a lot of, we didn't use a lot of evidence about how certain places were affected differently by PPD than others. And then we could have used that better in our presentation.
Okay. And final question. What is a way in which your team's resolution makes you think different about the research you conducted?
It makes me think differently because in my research, I spoke about how women dealt with their problems like mentally, and in the overall conclusion that we came up, I see that there's like more than one factor to the problems they deal with. It's not just like their own problems, but they also have to deal with economical problems and maybe like pressure by the people where they live.